Can everybody hear us?
Multiple
Yep,
attendees.
all right.
Okay, fantastic. Okay, be loud. We had one be loud. So I'll move the microphone a little closer just so we can.
Try to be as loud as possible.
Yeah.
Okay,
Okay,
so
fantastic.
shall we begin, RJ?
Yes.
All right. So, Melissa and Janinicas, we are here from the unceded and unsurrendered Algonquin territory in Ottawa, Ontario. So, as the Native Women's Association of Canada, we are a national nonprofit Indigenous organization who are representing the political voice of Indigenous women throughout Canada. It was incorporated in 1974 as a result of the activities of local and regional grassroots Native Women's Association over many years. And NWAC was formed to promote the well-being of Indigenous women within Indigenous and Canadian societies, and we focus our efforts on helping women overcome sex-based discrimination. So today, us at NWAC, we engage in national advocacy. Wow, I can't say that word anymore. Measures that are aimed at legislative and policy reforms that promote equality for Indigenous women and girls. And through this advocacy, policy and legislative analyses, we work to preserve Indigenous culture, advance the well-being of Indigenous women and girls, as well as their families and communities. And out of this work, we practice what we call a culturally relevant and gender-based analysis, which is very foundational in our work. And this CRGBA recognizes the need for a gender-based analysis that encompasses interconnected relationships between culture and gender. And it also reflects the historical and contemporary context and lived realities of Indigenous women, girls, and gender diverse folks. And it has become quite a pillar in our work to the point where we actually have people working full time in completing these analyses in all of our work and making sure that nobody falls through the gaps. So here we are here because we have a sexually transmitted and bloodborne project background. So we had was funded through FINIM. Of which we have developed culturally safe, gender-based, and trauma-informed fact sheets, and a trauma-informed service provider fact sheet, and a workshop guide that is targeted to Indigenous women, girls, and gender-diverse people. And these resources that were created throughout this project had a heavy focus on cultural safety and gender inclusivity. And in addition, these resources were focused a lot on addressing the stigma and the fear that Indigenous women may face when accessing health services.
One of the things I'll definitely say about this is that the resources that are going to be referenced throughout this presentation are all going to be available to you. Right now, they are currently on the NWAC's website in the STBBI, the little link on the website, and I will send them out as well to folks who are interested in. But that's primarily some of the work that we're going to be talking about and kind of how we got to creating a framework around transforming our responses to sexual and reproductive health. In order to do that, though, we do have to do a little bit of groundwork that comes with understanding the differences between sex and gender. Because while we are primarily working with Indigenous women, I think it's also important to know that there are conversations that need to be had that kind of separating gender identity and intersex people, and knowing the differences so we can also assist people who are gender diverse. We've definitely taken on gender diversity to be a key part of our work. And in order to be able to do any of the work around understanding trauma and intergenerational trauma and how colonization has impacted that, we have to look at some of the language that is around understanding gender and sexuality. So what you'll see here is a definition and how sex is the biological anatomy that we identify as male or female. And intersex individuals are whose biology, sex, is neither distinctly male nor female. One of the things that often happens within this work that becomes a barrier is knowing the differences between sex and gender. So sex is about the like biology makeup of somebody's anatomy. And I think that's important to make those distinctions because gender is less and gender is less about um, biology than it more is about identity. So gender encompasses identity, behavior, and expression, and around the way that we present to each other. So words like man, woman, like both or neither, people who would consider themselves like non-binary, those are words that are in reference to gender specifically. And if we go back quickly, we'll see that the words here, male, female, and intersex, those are words that might identify under, like a female might identify as a woman, but that's not necessarily the case. Sex is biological, and the words male and female is to represent like biology. But also, sex is not as clear cut as people like to talk about chromosomes a lot when we have this conversation. It's also not as clear cut as that because chromosomes aren't perfect in the way that people's bodies develop isn't perfect either. And there is a big, unfortunately, group of people, which are intersex people, who don't actually get identified a lot of the times, or they find out they might be intersex later in life. And this is key too, because this also increases understanding like health barriers that could come up later on in life. I definitely can give some more resources to have like more in-depth like knowledge around this, but this is super important when we're looking at health. Also, just being able to like understand that certain issues can come up around health if you are transgender, and that's also something that we need to like have conversations about. Um, Again, like I will be able to give more resources for people to have like more concrete understandings of this, especially too since a lot of the work I'm doing currently is within like understanding 2S LGBTQ plus people. And this is definitely a conversation that comes up. So we do have resources that will be available for distribution.
So when we talk about trauma, we refer to a traumatic event that includes the exposure to actual or threatened death, serious injury, or sexual violence through one of the following ways, which is either directly experiencing the event, witnessing the event, learning of the event, experiencing repeated or extreme exposure to adverse details of the traumatic event. And when we talk about intergenerational trauma, this is when the original trauma is transferred from subsequent generations through biological, psychological, environmental, and social means, resulting in a cross-generational cycle of trauma. And an example, it would be the intergenerational trauma is a legacy of the residential school systems or the 60s scoop, and any other discriminatory practices or policies that were enforced in Indigenous communities, which still affect Indigenous women and gender diverse people today.
So when we're talking about colonization, like Melissa had said, that there were strategies of assimilation, such as like the Indian Act and residential schools, the 60s scoop. A lot of these practices targeted to eliminate cultural practices, traditional knowledge, kinship systems, as well as our languages. Currently, we are feeling the effects of that right now. And we can see that by the ways that there are certain health barriers that are currently existing for Indigenous people that are specifically in line with understanding like colonization. There's a lot of issues around like understanding that addictions cannot exist without looking at trauma. But unfortunately, the conversations around addiction don't actually include looking at trauma. But if we were to actually take a trauma-informed approach when we're talking about addictions, we would ask questions like why does this person have an addiction, as opposed to the addiction is the problem, as opposed to understanding there's an underlying issue that's at hand. And a lot of that times it does go back to something that had happened to people that were out of their control. So there, unfortunately, this has a systemic impact on the ways that children are currently the highest in the children welfare system, and they're the highest being apprehended for like a lot of different reasons. But again, when you remove these pillars, which are pillars within Indigenous communities, taking away our language, our cultural practices, our traditional knowledge, these things are going to have impacts on identity. And they say that one of the most like decolonial ways to be able to like reclaim culture is to know your language. But if language was taken from you, how do we begin to have like conversations of seeing the world in a very particular view without that language? This has especially had impact on LGBTQ people. There was a history of gender diverse people from nation to nation. It looks very different pre-colonization, but those were some of the first people that were removed like through residential schools, because residential schools inherently gendered children into like girls and boys, and when you split people up in that capacity, you're also removing that there are people in these spaces who maybe didn't identify with the gender because of having like cultural practices around gender diversity, and how there is roles for people who kind of exist in between. And those were some of the first things that were taken away, and it's colonization and also just like the forcibly put into religion that really took those roles. And a lot of that comes back to conforming to roles that are not ours. One of the things that I also think is super important when we're looking at like systems like residential school, is to understanding the lack of consent within education. And I think a lot of the times we see a lot of Indigenous people currently struggling within schools. And a lot of that comes back to the ways that school wasn't consensual in the very beginning. There was a lot of trauma that happened within these schools that have created a lot of systemic impacts. One of those things is that we know that there has been a lot of sexual assaults and sexual violence that had happened towards Indigenous people within residential schools. On top of this, understanding like eugenics, and the eugenics is the taking away like sexual and reproductive rights of Indigenous women and women with disabilities, and pretty much other women of color as well. These are systems that had negative impacts in the ways that many of our people see the word sex and sexual health. And I think that's important to remember, and also see like within our current populations and our struggle and stigma around having conversations on sexual health. And I think that's super important to know, because we have to understand that the word sex and sexuality, sexual health, it doesn't matter. If your first association with that word is going to be negative, that's going to travel down through the generations. That's going to travel onto just like not being informed around certain issues around like sexual health in particular, but that's going to create systemic effects in terms of not trusting the system in terms of looking for like sexual health care. So one of the things I often tell people is that because of this, it is really hard for a lot of Indigenous people to talk about sexual health. And I know this from being an educator and being inside of spaces where there there were a lot of uncomfortable like feelings when you had a conversation around this particular topic. But also it shows that these words also hold a lot of power. So even the word sexuality, a lot of the times that there's a lot of stigma towards people of different sexualities because of the power that the word sex has within sexuality. Even though we know sexuality and sexual orientation isn't anywhere near sexual assault, these things are often conflated because words have a lot of power. And if this is going to be your first exposure to this and your first idea of what this language is, and knowing that a lot of us now speak language English because of this, there's just a lot of negativity that comes from these words. And if you are a service provider, having that understanding of wondering like, hey, maybe there aren't a lot of Indigenous people coming into my spaces that are like inherently about sexual health. A lot of the times that comes with fear, and a lot of the times too, like when we look at the ways that fear that is created within these systems that had previously harmed Indigenous women, and I'm talking about eugenics, I'm talking about the forced sterilizations that we still continue to see within the media. This isn't new news, and I heard about these forced sterilizations for years, and I can't express how this is just not new news. I think the only new part of understanding forced sterilization and how that is continuously happening in forced coercion, and that's to forcibly take away someone's reproductive rights or convincing them that it's a good idea that they um, get rid of their like reproductive systems. These are things that have been happening for a very long time, and I've seen this a lot when working in social work and how people had conditions, in particular for the Indigenous women, to leave shelters. So it's just like really to show that this is still a very important conversation, which is why a lot of people struggle with having conversations or even going to get like tested. A lot of the times, like they have been a part of systems that have inherently clinicalized them. It is said that if an Indigenous woman were to go through a negative experience at the in a doctor's office, or in any kind of like medical institution, and if she had a negative experience, the chances of her going back to that space like significantly decrease. And unfortunately, that results in seeing women, and often we see, and this happens a lot for Inuit women, that you'll see Inuit women coming in with stage 4 cancer because they had gone through a negative experience within a hospital, but also not trusting the hospital enough to go back. So then there are these very treatable, like if you got it in the early stages, we could have treated that. But because of these negative health experiences that they're having within hospitals, and a lot of that comes from trauma and also just continuously being mistreated by people, or just having this very lack of understanding, that creates this impact of people not wanting to have access to these systems. People not going to regularly get tested because of being nervous. And I think that's super important for us to continuously remember, whether you I don't know, I guess, the background of a lot of you folks, but when working with Indigenous women, to always think of the why. And if there's like a certain consequence that you're thinking of, or if there's a certain issue that this person is going through, or if there's a certain behavior, there's always a why that exists, or wondering why. And really, that's how we can move into trauma-informed care. One of the things that I often talk about when I talk about trauma-informed care is how trauma-informed care is actually just rules on how to be a good human being. So a trauma-informed approach to care recognizes the commonality of trauma and how trauma affects all aspects of people's lives. This includes interactions with service providers in order to create safe spaces for clients, working with Indigenous women and girls and gender diverse people. A it's a lot of words. A trauma-informed approach will acknowledge how the processes of colonization continues to impact the lived experiences of Indigenous women, girls, and gender diverse people. It doesn't mean that this person is reliving or reflecting on traumatic experiences, but instead emphasizing the strength developed from surviving trauma and how resiliency can actually really help foster healing. Failure to take trauma-informed approaches really causes re-traumatization. And this is what I'm saying when I'm talking about the women who tend to like go into healthcare systems for checkups and get mistreated, and then end up not going back. That's an example of what a failure to having a trauma-informed approach looks like. And it's unfortunate because this does happen a lot more than we think. One of the things. Also, sorry, I just seen your comment and it just made me smile. Sorry for pausing. This is the thing though, when we look at sexual and reproductive health education and interventions, they will have more success when service providers are able to address the possibility of trauma within people. Because again, like one of the historical things that we have to remember and continuously think about and not forget, it's not about not forgiving, it's about not forgetting and just remembering with intention. So remembering that If sexual assault happens and is very common within a population, there's going to be impacts in that person's life because of that. Whether that happened to them as a child, those things don't go away if it's unaddressed. So those are things that we always have to remember. It's super important to always remember, especially this within talking about sex education or sexual health, and just really like understanding how to change our response to sexual and reproductive health is to always understand and anticipate that colonization impacts these colonial systems that are a result of like having the Indian Act in place. Creates really problematic and harmful policies that particularly damage women. And I'm talking about the Indian Act in the sense of how Indigenous women who, for a period of time, who married out of their family had their status taken away. If they married someone who was non-Indigenous, that was something that was particularly targeted towards Indigenous women. And that's something that still has impact on that woman's children and then that woman's children's children, as if that marrying someone who is non-Indigenous suddenly means you're not native anymore. But these are particular, like, very clear examples of like racism and systematic discrimination that exists within our current systems, and how we need to be responsible around showing people that this doesn't have to be the norm, but that can only happen if we continue to learn more about trauma-informed care. It is really, again, just really important to, one of the things that we'll talk about today is to reflect on how our own personal values and our own beliefs influences the ways that we interact with clients. Because every single one of us carries a set of values that have been formed by a variety of different influences over our life. And these values can either be invisible, they could be visible, but service providers are no different and navigate their work lives through their own beliefs, through their own assumptions. And we need to actively question how structural racism has been built into health, as well as social services, and how this impacts our own ability to provide services to Indigenous women, girls, and gender diverse people, and how we need to do that in a respectful way as well. So now that we're kind of getting to that point, we're going to talk a little bit about intersectionality, and how intersectionality is a term that was coined by the African American legal scholar Kimberly Crenshaw in 1991. It's also Black History Month, so I'm especially grateful for this woman. So intersectionality describes the idea that identity and oppression are multidimensional and create complex, interlocking social and economic barriers. Though the term originally focuses on the law's failure to meet the needs of women of color who are both faced with race and gender discrimination, it's since grown to encompass all aspects of identity and social identity. So one of the things that I think is super important when we're talking about intersectionality is to like be able to recognize that we all have privilege to a degree. One of the things that I think is important when having this conversation is that I know you can't see me, but you see my picture at the beginning. I'm transgender, therefore I had lived my life looking like an Indigenous woman, and then decided later on in my life that I wanted a change. And it wasn't something that I can necessarily explain, other than it felt like I had been in the wrong body. When I talk about intersectionality, I think about the ways that now that I look more masculine and I look like a man, I now realize that I'm not afraid in the same ways that I was when I was an Indigenous woman to walk home at night. One of the things that I always knew growing up was murdered and missing Indigenous women is a very big issue. It is okay to be afraid to go out at night. That's just really common if you're an Indigenous woman. And to never go out without pairs, otherwise you could be in danger. So I grew up with this idea and understanding of fear when I look like an Indigenous woman, But from looking more masculine and kind of having that change happen, I realize now that I'm not the person that people are looking for anymore. Since I don't look like a woman and I look like a man, I know when I go and I'm walking down a dark path, whoever's walking on that path with me is going to walk right past me. And I think that's a privilege in the sense of there was a long time where I was afraid to um, walk down a path alone. My heart would race. I could hear my heartbeat when I was walking down a path alone, where I don't have to think about that now. And a lot of that just comes from looking masculine. So that's recognizing that gender identity can sometimes intersect with the values, or not values, intersect with your the ways that oppression actually like play out in our day-to-day life. So now when I think about my partner who is a woman who is afraid of walking home alone at night, sometimes I'll be like, hey, let's take this dark path because it means we can get home a lot quicker. But she's feeling scared and she's nervous because she knows that she's been harassed in this area multiple times in dark paths. So in that moment, it's important to recognize that I'm actually not the person who is going to be the victim in this situation. If something were to happen, it's actually not about me. It's about her safety and her not feeling safe. And just because I'm not going through something doesn't mean that that lack of safety doesn't exist. And this is super important when we're having this conversation, is to know that it is possible for us to have, we can be oppressed in certain ways, and Indigenous women, I believe, are oppressed, but I feel like being transgender creates a whole lot of different issues that exist within community. While physically I look masculine and I have more access to things than I did before, I'm losing access to certain things because of the ways that homophobia as well as transphobia manifests within communities. So I can recognize that there are certain areas of my life where I have privilege, and then there are certain areas of my life where I don't gain privilege because of just the overlayering of understanding these things. And I always think that being able to reflect and hear a person talk about these things makes it a little easier, especially a person who also has experienced oppression and knows what the opposite side of what that looks like, and understanding privilege. Because I think, again, it's really difficult sometimes to recognize that, oh, there are certain like privileges that I have that actually have given me a very set of particular values, and that inherently will project onto people, especially if you are working directly with people and with clients. Sometimes it might be a little harder to be sympathetic for people because you don't have that lived experiences, but sometimes it's about just reflecting on the things that we have, and understanding that these are complex, and they're multidimensional, because this is just one little piece of something that happens to every single person. So if we move forward.
Yeah, so the reason why it's very important to use a trauma-informed approach in sexual and reproductive health is mainly because you'll have increased success when if you learn as a service provider to learn to address the possibility of trauma success, such as sexual abuse or violence, only after building a trusting relationship. And it's important as well for service providers to acknowledge the impacts of colonialism, as RJ was saying earlier, through processes like the residential school system, the 60s scoop, ongoing theft of land and resources, gender-based discrimination within the Indian Act, and the forced sterilization of Indigenous women in order to establish healthy relationships and harbor safe environments of our clients and people who come and access services.
Okay, so tips on how to provide trauma-informed care. So I'm definitely going to be giving out some resources for sure on this, and we already have resources that exist. I will definitely link it to everyone, and I'm sure it can be sent out to everyone as well. But really, in order to be like trauma-informed, it's really just having questions or considering when you're working with people, what is the relationship of your community, of your client's community, between their community and family. Let's see, as someone who works in a small family, I hope you're able to Oh yeah, definitely. Sorry, I just yeah, I will be able to send out this presentation as well for sure. But yeah, tips on how to provide trauma informed care is like just thinking of what is your client going through, what is your client's home life like, does your client have a support system, are you aware of the word Indigenous and how that encompasses three distinct groups? So First Nations, Inuit, and Métis. This is something that I particularly have seen a lot happening when working in sexual health. So one of the things that I realized when I was doing presentations with like service providers who work in sexual health but don't necessarily work with Indigenous people is when they think of Indigenous people, they automatically defaulted to like First Nations people, which automatically defaulted to Anishinaabe people. And we can see health is like very Anishinaabe focused and very Haida focused as well. And those are things that we typically see within imagery, but that actually creates a lot of health barriers for like Inuit and Métis people. One of the things that I think is important is to remember that Indigenous is a word that isn't helpful in a lot of ways because of the ways that people like to monolith us. So when you're a First Nations person, you're also belonging to your own nation, and there are hundreds of nations across Canada. So a lot of the times, like if we are automatically defaulting Indigenous to like an Anishinaabe person, because that's usually who we would typically see or who we see represented in mainstream media when Indigenous people are shown in mainstream media, that neglects the fact that Inuit people have their, or not Inuit people, Inuit have their very own specific health needs that exist purely on the fact that they were from northern communities and they actually have to fly into a lot of more mainstream cities. Like Ottawa is one of the biggest cities that has a really high Inuit population because it is one of the most like one of the fly-in communities for them to get healthcare. So there's a lot of services here for Inuit, but one of the things that also when we tend to monolith words like Indigenous, we tend to fund a lot of money tends to go into what First Nations people are doing as well, as opposed to like Inuit and Métis. And those distinctions are super important because Inuit people don't consider themselves First Nations, and neither do Métis. They're their own groups of people, and I think it's even more complicated, of course, because First Nations is kind of like the word Indigenous, where it monoliths a bunch of groups. But a lot of the times when we see like health barriers and sexual health barriers that come up, it is going to be completely based on like the territory and like geographically where you are, because the health outcomes that exist in northern parts of Canada look very different in the south. For example, I know Saskatchewan right now is really high in terms of battling the HIV crisis, and there was a reserve where the chief was actually talking about how important it is to get tested. And since there was such a high like rate of HIV, I think it's super important to understanding. I think it's super important to understand that um, people in those communities have power in terms of being able to have certain conversations around sexual health. So, one of the best things that often happens in these cases is trauma informed care comes with being able to, if you're an organization, employ someone who looks like the people that you're trying to outreach to or you're trying to get services to. Um, Sorry, I'm just reading some of the questions. Yeah. Yeah, I also agree with Teresa was saying. Mohawks being talked to with Anishinaabe teaching is why mainstreams thinks I'm wrong and the teachings they learned is right hurts and many never return to the clinic. So also even from other nations, and I've met some Mohawk youth who always feel that they're excluded because everything is super Anishinaabe centric. So they're likely not going to go to the health center that's in town because it's mostly Anishinaabe. So that even there, that creates a health barrier where even our services, because we're monolithing and using a pan-indigenous approach, which is thinking like an approach where we kind of say that all Indigenous people are the same, which is not true. That creates issues. So, trauma informed care is really applying that practically, is to understand that these groups are distinct and they all have distinct needs. And it's important to really recognize that. Um, so, one of the things around giving trauma informed care is you don't need to know what trauma a person has gone through in order to provide trauma informed care. Being aware of your own positionality. And I talked a little bit about how, from being someone who was looking like a woman and kind of transitioning to looking like a man, how that has significantly changed the way that people interact with me. So I know that if I'm going to go do a workshop and it's going to be at a Indigenous Women's Center, I might not be the best fit for that if they're going to read me as someone who's a man, and I don't want to re-traumatize people in those situations. So I would recommend someone I know who maybe looks more like a woman, who looks like a woman and not as masculine as myself, to go do that presentation, because I don't think re-traumatizing clients is the way to do things. Being able to empathetically listen with clients is super important as well, and also empowering your clients to make the best decisions for their sexual health. And I think that's one of the big things that is super important. I also do agree. I think people need to treat people like people. Like, there's nothing wrong with that, but cultural sensitivity training is super important. Regardless, I mean, we'll talk more about this as we go along. I'm sorry, the chat is so distracting because I want to be interactive with people, because I'm really used to being interactive with people in sessions. But we'll move on to values and attitudes. So again, like, values and attitudes is just that understanding of, again, like, that we all have a set of influences over the course of our lives. And usually this is from family, this is from culture, this is from media. Media is a really, really big one. And also just having this just basic understanding around also, like, religion as well. A lot of different things influences our, like, values and attitudes. And sometimes we need to question how structural racism has been built into health. So that being said, is like, we have the birth control pill as of today. And when we look at sexual health, I think it's important to realize that I'm trying to remember her name, and I had it before I started. It's the woman who started the Planned Parenthood movement, Margaret, I think. Margaret Thatcher. It could be a totally different woman. But yes, Margaret. Um, this woman was very pro eugenics. This woman particularly went after women of color. Um, she went after women of color, went after Indigenous women, and went after women with disabilities. It is super important to realize that the reason why we have medical advancement in certain areas of understanding sexual and reproductive health and, like, birth control in particular is because women were tested with, like, these women were the ones who were tested first. So even when we're working in sexual and reproductive health, I think it's important to always remember that we have contraception as a result of testing that had happened early on in life on Indigenous women, on women of color, on women with disabilities. And I know this is often something that is really hard to remember, but I'm really strong about, like, agencies that are doing work in sexual health to, like, really make that acknowledgement. Because again, sometimes people don't know the history, but the history is also very grim. But that's also super important in terms of, like, when we look at structural racism, we have birth control as a result of structural racism, but we need to question the, like, I guess the values around, like, this was a bad thing that happened. But sometimes people will be like, no, this is a good thing that happened because we have all of these things. But we can understand that it's important to realize and really think of, like, the harm that this is done in a systemic way, in the ways that, like I said earlier, we still have practices that are impacting Indigenous women, specifically around forced sterilization and coercion. as a result from this woman doing her work early on. And it is important to remember and question, like, is this a good thing or is this not a good thing? And I think it is definitely important to question structures like health, because sometimes health can be super unfair. So again, it's super important, and I added this activity at the bottom if any of you want to download it. It's not something that we're going to be doing right now. Yeah, it's not something that we're going to be doing right now, but it's something that I think is a super important document, and it's just something that you can take away and do yourself. And it's I've done it with a group of folks. It's called, like, basically they're like statements, and you would add points depending on those statements to see how many you would get at the end. And then usually what we do, depending on how many you have by the end, can tell you how much like privilege you have in spaces. And it just allows us to think and kind of pause and reflect. And that's really the goal of it, is to get folks to reflect on different privileges that can exist, but not realizing those are privileges, to really just help us ground us in understanding our own values and attitudes and how not to project that. But I always found that doing this, I feel like, would have looked completely different a couple of years ago versus now. And it really just gives us an understanding of how other people just have very different lived experiences. Um,
And recognizing and respecting that traditional knowledge and biomedicine can coexist and can be integrated into sexual and reproductive health interventions. As an example, traditional ways of sharing information, such as storytelling and sharing circles, can be a very powerful way for Indigenous people to reclaim and share their stories of misconceptions, pain, trauma, stigma, while also reconnecting to culture. So sharing circles have potential to be very healing, and they can take a trauma-informed approach, and they are also a crucial way to help Indigenous people learn and unpack their perceptions of sexual and reproductive health, and to help destigmatize conversations about healthy sexuality, sexual health, and harm reduction. And it's through these conversations that we'll begin to turn shame into resilience.
so one of the things that I've realized around like sex education is, one, sex education tends to fail a lot of people, with depending on where you are and the curriculums that people are being forced to learn. But one of the things that I find from being a sex educator at one point in my life is how the one size fits all method that's often used in sex education is not helpful when you're dealing with other communities that have different learning needs and different health needs. So, one of the things that I remember really fondly was how there is this one workshop activity that we would typically do within a like sexual health session for teenagers, and we ran this in schools all the time. But the second that we decided to run the same activity with Indigenous people, it completely shifted the conversation around people disclosing moments of violence in their life and sexual assault because of the ways that the questions were laid out. And a lot of the times we ask youth, what was your first experience, or like your first like idea, or like being exposed to like sexuality, or sex education, or not even that, even sexual health. And sometimes those questions make a lot of sense for a group of youth in high schools, and it was one of our most popular tools. But then when we changed it around for Indigenous people, we got a completely different result. And that made me realize that the one size fits all approach is only good for some people and not all people. So, how do we have more conversations with Indigenous youth? I would like to have more how do we have more conversations with Indigenous people about sexual health? It's important to take an approach on understanding that every person, or every way of communication that we have is very cultural. Communication is cultural. Conflict is very cultural. The way that we learn and the way that we teach should be very cultural as well. So when we're thinking of that, the reasons why being able to like have trauma informed care coexisting with traditional knowledge is being able to, like Melissa said, have those circles, because um, it was different when I was standing in front of a group of Indigenous people talking about sexual health to them versus me sitting in a circle with them where we can have medicines together to have difficult conversations. And before we could even get to the sexual health stuff, we found that talking about stigma and where our fears came from around sexual health and what stopped us from being able to talk about sexual health in the workplace, um, especially with people who are working with youth, was especially important if we wanted to actually get to a point where we felt comfortable enough to do this education. And I found even being a sex educator, or at least starting off, I always like think back and laugh a bit because I remember the days where I couldn't say the word sex without feeling my voice drop. And I feel a lot of people who work in sex education might have that at some point. And a lot of that just came from stigma and just like recounting the amount of shame that I heard and understood as someone who grew up as an Indigenous woman, what that means to me. So I think it's always important to find ways to have these really difficult and vulnerable conversations in ways that are comfortable with the populations that you're teaching. And with Indigenous people, it's actually in the circle. And I went as far as to like we would open with a smudge, and it was really awesome before we started talking about stigma, and then we would all go in a circle and talk about stigma. Um, that was fantastic, and we would even instead of using a talking stick, we would use a beaded vulva. Who I got it from this really fantastic beater here in Ontario. Actually, she might be in Quebec. Actually, no, she's in Ontario.
She's Ontario.
Yeah, she's in Ontario. But it's a good teaching tool because I find too like Indigenous people are very creative, and having something like that looked very abstract, like a beaded vulva, is a good way to kind of have a laugh. So also too, that incorporates the importance of bringing humor into these spaces in ways that are appropriate, of course. But Indigenous people are funny and they like to laugh. So I find being able to have an uncomfortable conversation, using something like a beaded vulva, and also having people like inherently touching something that makes them think more in depth about these things or really do some more reflective thinking. It's a good way to kind of build that bridge. So art is a fantastic tool. Another method that I would say around like traditional knowledge and trauma-informed care coexisting, especially with Indigenous people, is like doing art while you have a conversation. So the Native Youth Sexual Health Network is really good at doing talking about sexual health, but also doing these really cool beaded condoms. And it is exactly what it sounds like, beaded condoms. You'll have to Google it in order to believe it. But it's also a conversation starter, and that's what I like about art, is how it can be a conversation starter. I would go into friendship centers with that beaded vulva, and start conversations with it, and then we would talk about stigma. Of course, it doesn't have to be a vulva; it could be anything, but it's a good way to kind of create a comfortable bridge for people who might be uncomfortable having conversation. This also goes back to my comment earlier where I said consent is often lacking within education. Um, One of the things that I think is super important, especially when we're doing sessions with people who are Indigenous, specifically on sexual health and sex education, is giving people consent to leave if they need to. So, one of the things that I've realized is that when you're working with a population that has a high percentage of sexual violence or sexual assaults, sometimes talking about sex is just really triggering. And I think one of the things that residential schools has inherently taken from us is the consent to learn. So I think creating a healthy and a equitable learning environment, actually be able to um, you need to be able to give people the opportunity to leave if they need to leave. So one of the things that I tell people in the beginning is that we're going to talk about this. I give people the outline of everything that we're going to talk about, so they know what is going to be held within the conversation, and then I will tell them then I'll tell them, like, if you are uncomfortable, you are allowed to leave. If you are uncomfortable and you need to disassociate, and you need to be on your phone to do that, that's also okay. And I think the most important thing is around sexual health is that if you're uncomfortable and you feel like you're being forced into that place, then this conversation is going to be re-traumatizing. This conversation is not going to be welcomed with open arms. So really understanding that no one should be forced into having conversations of sex education, especially when there is a history of understanding that trauma exists as a result of the violence that happened through colonialism. So that's one of the big things that I think is key, is like making sure that all of your education has like a focus on consent, and even being in that space. That's a physical tool that people can walk away with. We're going to practice educational consent. And what does that look like? It means giving people the opportunity to check out when they need to, or allowing people to leave that space if they need to, and really giving people tools of saying, like, I think everybody should be taking care of themselves first in these conversations. And that could look like not being here. So I think that's, again, a really important way that we can kind of focus around like traditional knowledge and the ways that sharing circles allow us to do all of these things that I'm talking about, in ways that me standing in front of everybody doesn't. And I inherently feel that when you are sitting with a group of people talking about sex education, you're also one of those people. You're also learning from them. And I think that's a really special opportunity to be able to have that in a space, especially around a conversation that is going to be inherently intimate. Okay, so questions, again, a lot of these things are, yes, empowerment is definitely key. Another thing, just like, oh, I'll quickly go back. Another thing I'll say on this is, again, empowerment is key. I agree, Kimberly. Thank you for bringing that up. One of the things, too, is like it can be a bit of a learning curve, I find, like hosting these kinds of circles, but always making sure people leave in a positive way. So, usually, when hosting a circle like this, I would definitely suggest on making sure you end in a way where people are feeling good. So sharing a story where everyone, where you can learn something from it, but learn something that is really positive. Because I've definitely been a part of circles where these kind of learning circles where you feel super heavy at the end and don't feel so good. But other times it's like I'm feeling content, I'm feeling good, and I'm feeling like I can learn. Um, but yeah, sorry. Empowerment is key. So again, questions to consider when working with Indigenous women, girls, and gender diverse. Again, we talked a lot about this already. What is the relationship of your client between their community and family? What is your client's home life like? Does your client have the support system that they need? Are you aware of the word Indigenous encompassing three distinct groups? And Indigenous women and girls and gender diverse are strong and resilient and focus on their strengths instead of the defects that exist. So again, remember, you don't need to know what trauma a person has gone through in order to provide trauma-informed care. And I think everyone thinks the word trauma-informed care is this big scary thing, but I'm purposefully doing this presentation in this way to show people it's actually a lot simpler than people think it is. Being aware of your own positionality, being able to practice empathetic listening with clients, and empowering your clients to make the best decision for their sexual health. So again, to further your understanding of trauma-informed care, consider exploring the concepts of forced sterilization of Indigenous women, intergenerational trauma, vicarious trauma, and cultural safety. These are 4 frameworks, including like harm reduction, that really allow you to practice some of the most wholesome ways to have certain conversations not be so intimidating. Okay, I think this is where we switch off.
Yeah, so thank you to RJ and Melissa for that really informative and also very thought-provoking presentation. So I think we have just a few more minutes. If any folks have questions, please, once again, or comments for RJ and Melissa, you can use the chat function. In the meantime, I'll just go through kind of, again, a few housekeeping items. We invite you to register for our next webinar being held on February 20th. That webinar is looking at understanding sex work and stigma in Canada, and it's being presented by HIV Community Link. So you can access the registration details with the link on your screen. And then please do take a few minutes to complete the evaluation survey. That will help the Native Women's Association of Canada as well as CPHA improve future webinars. As I mentioned, this webinar was recorded, and so we will be sharing the recording. We will be posting the recording on CPHA's YouTube channel in 1 to 2 weeks. So you can look for that there. You can also access more information about this webinar series or some of CPHA's resources using that link, or you can connect with me directly. Just while folks are posting questions or comments using the chat function, I will say that I know RJ and Melissa both mentioned that they could share the PDF slides. I will be sending an email out tomorrow afternoon with the links to the evaluation survey and also the links to register for future webinars. So I can also include the links to the PDF slides. And I see that RJ and Melissa are sharing a few different resources that they've referenced throughout their presentation. So I'll make sure to include those links as well. So I have a few people here. I see that they're saying thank you, a very informative presentation, definitely. We'll just wait a few more seconds to see if anyone has anything else to say. Otherwise, thank you all again for participating in today's session. Thank you again to our presenters. Very informative and really great presentation. All right, so it sounds like everyone's signing off. So with that, I think we'll close. And thanks again and have a great day, everyone.
Thank you, everybody.
Have a good day.